Hello, I am Dr. Lula Rahmani. I currently work as a consultant anaesthetist in Galway University Hospital in the west of Ireland, and I am delighted to be here present with Associate Professor Dr. Alana Flexman. Professor Flexman is the Clinical Associate Professor of Anesthesiology of the Department of Anesthesiology, Pharmacology and Therapeutics at the University of British Columbia. She works as a clinical anaesthetist in St. Paul's Hospital and Providence Healthcare in Vancouver, where she's also the Director of Research. Professor Flexman specialises in neuroanesthesia, and her research aims really focus around optimising better outcomes for high-risk populations, particularly the elderly. In addition, she's also the inaugural Vice Chair of the Equity, Diversity and Inclusion in the Department of University of British Columbia. She also holds that position as the Associate Editor of Equity, Diversity and Inclusion for the Canadian Journal of Anesthesiology. And furthermore, she is the present Editor-in-Chief of the Journal of Neuroscience, Neurosurgical Anesthesiology, having been the past president for the Society of Neuroscience in Anesthesiology and Critical Care. Professor Flexman, it's a pleasure to have you here with us, having just delivered the prestigious Ellis Gillespie Lecture, where you thank you for being with us. You really focused on how we can do better for patients who are needing our services towards the end of life. And I'd love to know a little bit more on your opinions around frailty, how we can better identify frailty, and how we can optimise care for patients with frailty who are undergoing surgery.
Yeah, thank you. It's really a pleasure to be here in Australia. Yes, it's a complex topic that encompasses a lot of different aspects of patient care and patient evaluation, but it's something that it's clear it's becoming more and more challenging in our practice, I think, over time as our population ages and frailty becomes more common, and also I think our advances in anesthesia care have allowed a lot more frail and complex patients to come to the operating room, which makes it more challenging, good for patients, but also challenging. Yes, so it's a topic that I'm interested in. I've kind of evolved in my research as well into moving towards, patient-centered outcomes and especially cognitive outcomes, and I think that especially is applicable to the older population. Yeah.
And in terms of those outcomes, what would be some of the key outcomes to consider in these older patients who are experiencing frailty and undergoing surgery?
Yeah, so the key outcomes, I think, when you ask patients, and this is kind of around also my interest in value-based care, which is, what are the outcomes that are important, and then also associating with the costs required to achieve those outcomes. And the outcomes that I think patients, when you ask them, there's been a few studies looking at it for older adults, and they really care about complications that happen to them, and they also care about disability. So they care a lot whether they will be able to do what they used to do after the surgery. And that's not actually an easy thing to measure all the time, and it's not commonly measured. So we often lack that outcome to base our practice on. But the research is moving in that direction for sure, which is looking at more patient-centered, impactful functional outcomes for these older patients, and about quality of life, because I think that's critical, because you can fix someone's problem, but if you leave them with a lot of extra frailty and disability, it's not good for the patient. So yeah.
And in terms of areas of research, there's a lot focusing on trying to reduce perioperative delirium.
Yeah.
And I wonder if you could share with us some strategies around how we could reduce perioperative delirium in this patient cohort.
Yeah, which is critical because it's probably the most common complication almost in the older cohort, and there's really good evidence-based evidence for bundled care packages. So like the Hospital Elder Life program, which I mentioned in my talk. But there's also sort of modified help programs that are even simpler, because I think in surgery we often struggle with all the components, and even though it seems very self-evident that the patient should get up and move and eat and do these things, it's actually in practice very hard to do that sometimes, and it requires resources. So at our hospital we've That's been one of our quality improvement projects, and one of the things I'm fortunate to be able to work with a lot of allied health professionals who actually were doing their own program around it's called the independence model, which actually helps patients do things for themselves while they're in hospital and achieve them discharging earlier, and not little things like brushing their teeth or getting out of bed or getting physio involved to help them move. And so that's actually been really good, and we've achieved, I think, some reduction in our delirium rate with our older adults. But it's also highlighted a lot of the challenges. When the patients are in our critical care area, they have a lot of trouble moving around or getting up because they're attached to monitors, and it's just more complex. And so, it seems easy sometimes, but it's actually quite challenging. But I'd say the bundled care pathways are the best thing, which include typically mobilizing the patient, helping them with feeding and brushing their teeth, and then and getting them to eat earlier rather than later, and minimizing lines. So enhanced recovery, basically. Yeah.
Easy to do on paper,
yes.
very challenging to implement.
In our health system,
yes,
anyway.
Absolutely.
Yes.
I think that's probably true across all health systems.
Yes.
Ours included.
Yeah.
And finally, you have a wealth of experience around this population, the elderly population, frailty, undergoing elective and emergency surgery. And I wonder if you could share with us a little bit about your approach around shared decision making, especially in terms of family members who might have differing expectations. The term they want everything done, or how do you approach those conversations with those families?
Yes, and it's very challenging, and I don't want to. I'm definitely not, have figured everything out. So I can offer a bit of what I typically do, or what I've learned from just reading, and just evolving in practice over many years. Is typically so the shared decision making is not something that I was taught to do, or that I actually have a lot of training in, but there are decision-making tools. And a lot of it is actually asking questions about what the patient and the family wants in terms of the outcome afterwards, rather than focusing on the short term. So like, is taking out the tumor today the issue, or is it that you want your loved one back home with you, within a month or something? And I think sometimes just taking time to ask questions and involving the family. I actually think, and this also comes from my experience from the other side, when I've had family members in hospitals, you're not always even included in the discussion. And I understand, I think that's a time thing, and people have trouble sometimes, in the rush of the pressures of clinical care. It takes time to find time to talk to a family and to talk to the patient. So I think everyone's doing their best, but if we have more time, it's better. One of the things we're in our practice, if we have people who have greater expertise in palliative care, geriatrics, or complex care. We have a transitional pain, so we have people who can take extra time to talk to the patient and family as well, and that is a very helpful supplement to when you are in the clinic and you don't have a lot of time. You have a tight schedule. You can't necessarily spend an hour with the patient and their family talking to them. So I think sometimes a referral to somebody who has more time and has additional expertise can also be really useful for us. To have them also assist with that discussion. And definitely our geriatricians, we have a great relationship with them, and they are very helpful when I've had cases where I also felt like the surgery may or may not be a good solution. Sure. It allows a longer discussion, and they do a very thorough functional assessment and goals of care with that patient, and then we can all have a discussion after that about what the best thing is for the patient. But it's challenging. I don't want to minimize, for everybody. Yes.
Well, I'd like to take this moment to thank you very much for giving us your time.
No problem.
For being here with us today, and for sharing with us some of the key snippets of what was a fantastic lecture.
Great.
And we look forward to the rest of your talks today.
Great.
So
Thank
you very much.